The issue of emergency overuse is real, but it's not as big as it's been advertised. The Center for Disease Control every year studies this, and for the last 2 years running, they've said that 8% of patients are there for what they deem to be non-emergent conditions or non-urgent conditions. But how they define that is that you're still supposed to be seen within 24 hours for those cases. So it's not as benign as it makes it out to be. So there is a piece of that that exists, but it's not necessarily that big. We all benefit from reducing unnecessary emergency department use. The reality is that we've seen an increase from 124 million visits to 136 million visits in the last year. That's a significant change. Yet we're not building new hospitals or new emergency departments generally in this country. And as a result, that means we're doing more with less resources. So if we can get the small subset, that 8% of non-emergent conditions, out of the emergency department to other places, we'll all have more space and more ability to provide care for the true severely emergent conditions. Additionally, we'll all save because we're going to be saving money for the state. We believe the alternative program can save us potentially $30 million a year, which is a significant amount of savings for the state. So we're excited that this can benefit everyone. Well, the alternative plan is a big plan. It's ambitious, but it's obtainable. What the alternative plan does is it works to integrate and actually build a system of care rather than independent silos. So one of the first key things that it does is it builds an information exchange that will communicate with all hospitals in the state rather than just each hospital or each system having its own silo of care, even if they're 6 blocks away from a competitor. It will also work to have narcotic controls and prescription monitoring programs and guidelines for prescribing so that we're not doing long-acting narcotics. In many ERs, we're not doing Percocet or oxycodone out of the emergency department for conditions that are considered to be more minor, and other guidelines and controls. Additionally, it'll allow us to look at their prescription database history of what they've been given from their primary care provider or their specialist so that we can reduce that utilization. This program is also going to target what's called the PRC client, or the patients requiring coordination. Those that are either chronically ill, have concomitant psychiatric or drug dependency issues, and those that need a little bit more coordination and maybe overutilizing emergency services. And for those patients, we're going to make sure we have care plans in place for all of them. We're going to work to identify them early and enroll them in the PRC program. We're going to get them 72-hour follow-up with their primary care provider so that they can get in to be seen for their chronic issues in a more real-time manner. Additionally, and I think one of the most novel parts of this program is looking at physician feedback reports. And what this is going to do is give data to physicians about how they're prescribing medications, about the utilization in their emergency department, about their resource utilization for those patients, and let us to begin to change the way we practice, to try to reduce the outliers and the variables that may exist in how each of us practice and make it a little bit more standardized. The reality is we're all driven by data, and I think this will help really pull in the range of care that we're seeing provided. Patient education is going to be critical for this. It's going to start in the primary care office with talking with patients about when to utilize emergency services. It's going to require getting patients in for same day and next day appointments so that they feel comfortable waiting for that next appointment that exists. It's going to also take changing the old answering machine that says that if you have any concerns, please feel free to go to the emergency department. And many primary cares are already doing that, but we need to reach out to those folks to get that message necessarily off the recorders. In the ER, it's going to take intervention by the physicians that are there to say, you know, this is a visit that potentially could have waited until you saw your primary care doctor tomorrow like they offered you in their next day appointment. Or did you think about an urgent care that might be a lower cost center for them to utilize? And for our frequent flyer population and for our patients requiring coordination, those PRC patients, an excellent opportunity to have a conversation about, you know, this is your 13th visit for abdominal pain. I think we're beyond the emergency part of this condition, and I'd love to get you back to your primary care provider. How can we make sure that happens in the future? So there's a lot of education that needs to go on to get folks to the right place at the right time, but I think it's something very easily obtainable. There's a lot of information out there already, and we're actively updating it. So the first thing I'd say is if you have specific questions or needs, please don't hesitate to let us know. The Washington State Medical Association at WSMA.org, the Washington chapter of the American College of Emergency Physicians, WashingtonACEP.org, and the Washington State Hospital Association, WSHA.org, all have websites dedicated to this issue that are going to be constantly updated, and more information is available. The WSMA and Washington ASAP focusing a little bit more on the provider issues, WISHA focusing a little bit more on the hospital issues, and some guidelines and draft policies that might be useful for implementing the various parts of this component. But again, the key thing is don't hesitate to reach out to us. We're on a tight timeline, but we can make it happen. We just need to know what you need to be successful.